So, good afternoon, everyone. My name is Victoria Austin. I am the co-founder of the GDI Hub and also an associate professor here at UCL in London. It's an absolute pleasure to join you this afternoon to share the work that we've been doing on the country capacity assessment on access to assistive technology in England. Before I begin, I'm going to first of all hand to my colleague Kate, who will give an overview of the access features of this broadcast today. Over to you, Kate.
Hello, everybody. I'm having a tech fail there. So welcome to the webinar. We've got two British Sign Language interpreters with us today. So we're going to change between the two of them every 15 minutes. We also have closed captioning available, and that will be shown in the bottom of your Zoom screen if you press the CC. Otherwise, you can view it in an external URL, and I've dropped that into the chat function. We have turned chat off for this webinar, but you can ask any questions into the Q&A, and we'll either answer those as we move along by replying with text, or we'll save some towards the end for a live Q&A. So please do add any thoughts or reflections into the Q&A function. But a warm welcome to you all, and we're looking forward to getting started.
Thank you so much, Kate, and a huge thank you to you and all of the team in the background who've been enabling this today, including some of the tech challenges that we've been having, which you might be able to see on the screen with some of the pixelated files, but we're working on it. I'll take this opportunity to introduce our team, and I'm going to take you guys in the order in which I see you. So I'll begin with Deborah Lennon.
Hello, good afternoon, everybody. I'm Deb Lonnan. I'm one of the team leaders in Disability Unit in the Cabinet Office. My team has quite a broad portfolio. It includes assistive technology, and that is why I'm here today.
Thanks so much. Next person I see is Zoe Clark.
Hi, I'm Zoe Clark. I'm Environmental Controls Lead with the Barnsley Assistive Technology team, a team that covers the whole of Yorkshire and the Humber for electronic assistive technology. And I'm also Lead Healthcare Scientist for my NHS Trust. Thank you.
Thanks so much for being with us. I see Jamie and then Anna.
Hi all, my name is Jamie Dinnemeyer. I'm a researcher with the GDI Hub for the past 4 years, and my background is in demography, so I focus on how we measure population level access to assistive technology.
Hi all, I'm Anna. I'm also a researcher at GDI Hub. I worked on many of the qualitative parts that you'll see today of the Assistive Technology Assessment, and I'm also a user of many types of AT myself.
In addition to being our background tech support, Kate was also a researcher on this project. Kate, would you like to introduce yourself?
Yeah, hello everyone. I have the pleasure of working across the comms and research team, so it's great to be here today to be able to share the findings.
Thank you. And Kathy.
Hi everybody, I'm Kathy Holloway. I'm a co-founder of GDI Hub with Vicky. I'm a professor here at UCL, although I am actually in the University of Salford today, but I'm normally at UCL. And I helped, I suppose, finalise the report more than anything else. I think Vicky gave me the title of Chief, what was it? Reference Checker. Which is, so if there's any references incorrectly in the report, you can blame me.
It's always good to get a professor to do those types of tasks. I spy Cameron.
Hi everyone, great to be here. My name's Cameron Malik. I'm Chief Exec of Disability Rights UK. We're a disabled people-led organisation based in the Olympic Park near GDI.
Thanks so much. I spy Delisha and then Mark.
Hi, I'm Delisha Patel. I'm a research fellow at the GDI Hub, and I supported the team with a qualitative analysis in this report. And I'll hand over to Mark.
Thank you. Mark Hoskinson. I'm Chief Executive of Scope, and delighted to be involved with this this work. It's a really key area. So look forward to speaking on the panel later.
Thanks so much to everyone. If there's anyone I've missed, shout now. Okay, then we shall move on to the next phase of our report. So as most of you know, we've had the delight of working on this project, which was published actually back in June. So the full report is available for you. Today, we're going to take a minute to, first of all, make some introductions and introduce the work and the report that we were doing. And second, we're delighted that Deborah will give us an overview from her perspective as the client on the project. Following that, we'll share the findings of the research, and then we'll have some interventions from the partners that we worked with along the way, many of whom you've just met. So I guess it comes to me then to introduce GDI and the work that we've been doing that have made us so excited about doing this work in the UK. Global Disability Innovation Hub, for those of you that don't know, is a research and practice centre. We are based at the University College London on Queen Elizabeth Olympic Park, right next to our colleagues Mark and Cameron. And we have been operating since about 2017. And our mission is to drive disability innovation for a fairer world. We've been doing that in lots of countries around the world. I think we're up to about 71, and we've reached about 30 million people so far with the work that we've been doing. And it was inspired by the London 2012 Paralympic Games, which myself and my co-founder Ian McKinnon and many other people were involved in the delivery of, and especially the legacy from. And so it's very special for us to have had the opportunity to have worked on programmes globally following 2012. A lot of that is funded by UK aid, and the programme name is the Assistive Technology 2030 or AT 2030 programme. It works in countries around the world to drive access to assistive technology. And I say that because as part of that programme, we've been able to improve access to assistive technology like wheelchairs, hearing aids, eyeglasses, digital devices, and many others, with support from and in delivery partnership with many other partners, one of which is the World Health Organization, and another is Clinton Health Access Initiative. And both of those organizations help to deliver and develop the tool for country capacity assessment measurement. We've tested it through the programme in 10 or 15 countries around the world, probably more now. And so to be able to have the opportunity to take a piece of work that the UK has funded, a tool that the UK has funded and that has been tested and used in countries around the world, and to bring it back to England to actually use to assess our own performance, was a moment that was very important for us and something we were desperate to do, and kind of tried to move hell and high water to make possible within the time frame and budget. And so it's been a pleasure really to work with this partnership. It's probably the most fun project I've ever worked on. And we're really delighted to present to you the findings today. I think when you hear the findings, and some of them are in the Disability Action Plan consultation document, you'll see we've got a way to go in England, and that the situation is not dire, but it's also not excellent. And we hope today to add some nuance to that argument in terms of explaining where we collectively in England and beyond in the UK can do a great job on ensuring that disability inclusion is a reality for everyone, disabled people, older people and others living within our country at this time. I won't say more because time is hit and I want to stay on time. So it's my great pleasure to take the opportunity now to introduce Deborah, who's already introduced herself, to give us a short address from the perspective of the disability unit which commissioned this work. Over to you, Deb.
Thank you so much. Thank you for your opening remarks and also for the opportunity to speak to you today at the digital launch of the England Capacity Assessment. I am very pleased to be here. The research was undertaken to improve the evidence base on disabled people's understanding, use of and access to assistive technology. And this research was part of a commitment in the National Disability Strategy that we published in 2021 that sought to establish a centre for assistive technology. That commitment was paused due to legal action, and we're awaiting a ministerial steer about how and when we recommence that work. But as part of the evidence base that would inform that commitment, we did commit to fund the assessment that we're here to talk about today. The wording is DU will assess the assistive and accessible technology needs of disabled people in England to establish where these are being met and where improvements can and should be made. And having read through the report, I'm very happy and confident that we're well on the way to actually firming up that evidence base. as everybody here today will be aware, ATEC has the power to transform lives. It can allow disabled people to break down barriers in education, employment, independent living. But also, I was in a round table on assistive tech the other day, and one of the observations was it's all very work and education focused, which is, of course, really, really important, but also for the joyful things in life as well, being able to participate in sport or cinema or theatre or in people's communities. Assistive tech can be so helpful, for example, people with a visual impairment who use an AI-powered app to turn their phone camera into a sighted assistant. But it can also be really simple. It can be as simple as a potato peeler that works for somebody, and as complex as cybernetics building a digital bridge between a paralysed person's brain and spinal cord, allowing them to walk again. All of those things on that spectrum are important to the individual. Accessible design benefits everybody. We've seen with the way captions become part of how many of us consume video, whether we're disabled or not. For example, 85% of Netflix customers in the UK use captions now. And there's a huge amount to digest in the report. Some of the things we thought were likely or we had a sense that were true, we now have that data to back them up. Colleagues here will go into great detail, but things like postcode lotteries, individual access to ATEC, knowledge gaps in what is available, what might work for individuals, and cost pressures. And this really helps us as policymakers with an established evidence base to help us develop workable policy solutions. I'll finish just by mentioning what has already been alluded to, our current work plan. We're currently consulting on the Disability Action Plan, which sets out the practical action the government will take to the end of this parliamentary term to improve disabled people's lives. I'll put a link to the consultation in the Q&A for people. And there are 2 ATEC measures in with that consultation. One of those is ATEC awareness training for civil servants. That builds on a partnership between DWP and Microsoft to train Job Centre Plus work coaches. And also the second thing, I'll pop in a little bit of a teaser trailer for some of the findings there. We're also consulting on the potential to appoint an ATEC champion. That's one of the recommendations in this report. And I'm really keen, as the conversation develops today, just to listen to people's findings and observations in response to the research that's been done, but also just in terms of kind of like, a wider appreciation of your ATEC use as well. Thank you once again for the opportunity to talk to you today. I don't often say it's a privilege to come to these things because that's just like what you're meant to say, but it truly is a privilege to actually be involved in this project. I feel very strongly that the research and the findings are just helpful, fundamental building blocks in how we approach assistive and adaptable technology, but also in a broader sense how we refine disability policy in the UK, but also how we ensure that we are inclusive of disabled people.
Thank you so much, Deborah, for that really thoughtful and genuinely interesting contribution. And also to you and your team for being a wonderful client. We should give Maxine a shout for all the help she gave in moving this project forward. It's not very often that a project like this is delivered on such a time frame, and it's often difficult to convince the government to do the research before taking the policy action. So I'm so grateful that in this country, the government did listen to that and we were able to bring forward the evidence, which is now informing future strategy. So we'll move on without further ado, if it's possible to move the PowerPoint forward to the opening section and begin with the research findings. So what we did is a piece of work to investigate the access to assistive technology, or AT or ATEC, and you will hear all of those words today, in England. We began the work in November and delivered it by the end of March. And with Christmas in the middle, it was a fairly tight turnaround, which is why we're so hugely grateful to the partnership that GDI Hub and UCL collaborated with on this. That's the British Association of Assistive Technology, Disability Rights UK, Scope, Staffordshire University, and last but definitely not least, Opinium, who provided access to the data for the survey. We did both a qualitative and a quantitative data piece, and we collected that data across mainly January and February and held some workshops with participants across the different themes. Next slide, please. We organised the approach to the country capacity assessment to address 3 research questions. What are the met and unmet population needs in terms of access to assistive technology in England? And we focused on disabled people as identified under the legislation in the UK. The second question was to understand the country's capacity to meet that met and unmet need. And the third was looking at the impact of assistive technology or AT or ATech on the people that use it. These research questions were interesting because, as to my knowledge, the UK is the first, or England is the first country to have chosen to undertake this survey in the way that we did. If you go to the next slide, please. The WHO, World Health Organization, has an approach to assistive technology, and we're the WHO's collaborating centre, so we work very closely with them, which brings together a number of tools to measure these research questions, and we integrated them all into one approach. So I think it's the first time it's been done, and it's the first time it's been done with a focus on disabled people. We did a literature review, and then, well, we did a survey using the WHO RATA, or Rapid Assistive Technology Assessment tool, as well as qualitative research, as I've mentioned. And the theoretical framework, for those of you that are interested, that we used was the WHO's 5 Ps framework, which puts people in the centre, but of course also cares for provision, products, personnel and policy, very much under the guidance of universal health coverage and the CRPD. Next slide, please. So I'm handing to Jamie now, who is our magic wizard, to tell you about the RATA survey findings.
Right, excellent. So I'm going to talk about some of the quantitative findings that came out of the Rapid Assistive Technology Assessment Survey. We did 2 nationally representative samples of individuals. We surveyed 2,008 individuals of the general population, for which we did not require any identification of having a disability or not. And then we achieved a sample of 7,253 individuals who did identify as having a disability via one of a myriad of ways we provided at the start of the survey. So these are the sample sizes that came after we adjusted for national representation based on region, age, gender, and ethnicity. So among the general population sample, we found that 65% use at least one assistive product. Most often this was glasses, and 19% met the WHO definition of needing an assistive product, which we used as having a lot or cannot do at all levels of difficulty in any domain of functioning. Among the disabled population, we found 87% use at least one assistive product, 45% met that WHO definition of needing an assistive product at all. And of these individuals, 31% reported having an unmet need for an assistive product. And we found this need was highest among young people and also in London, which may reflect a difference in awareness about assistive products, perhaps being more likely to report an unmet need for something. And we found less variation amongst gender, ethnicity, and middle and working class than we had initially expected. We also found that the assistive products with the highest use also often had the highest unmet need. And if Louise, you could go to the next slide, we can look a little bit closer at this. So this figure shows the products. I sought to create a list of the 15 products that were the most used and the 15 products for which we had individuals reported having the most unmet need. And this is among the sample of people with disabilities. And often these products would be one and the same. The ones that were being used a lot were very commonly reported that there were unmet needs for these products. And a lot of these were around mobility. As you can see sort of towards the left side of the graph, things like grab bars, canes and sticks, shower chairs, and all of these types of things. But we also see very, very high, we see unmet need exceeding use for the more expensive and more complicated assistive products like electric wheelchairs and even manual or like any wheelchair that has postural support. Next slide, please. So among individuals who reported having an unmet need for the assistive product, they're asked why they don't have the products that they need. And cannot afford was the most frequently cited barrier, cited by 45% of participants with unmet need, as well as lack of support by 19% and stigma or shyness by 17%. We did find that cost was more prohibitive for working class respondents. 53% reported cost as one of their reasons for not having the products they need, but it was also a problem for middle-class respondents at 38%. Female respondents more often cited cost. However, males more often cited availability, suitability, and time as barriers to assistive products. And we found that young people between the ages of 2 to 17 had the highest unmet need, and they cited barriers other than awareness. So older adults often cited other as a barrier, so they were able to write in a barrier if one was not included on the list, and they very often mentioned the wait time for assessments as being a barrier. So that's a barrier that I think we could just add the next time we plan to do a RADA in the UK. And I think that is all for me. We could go to the next slide.
Hello, I'm Delisha Patel, and I supported the team with a qualitative analysis along with Kate and Anna, who we will hear from shortly. So we thematically analysed the in-depth interviews and with key stakeholders and users of AT and focus group discussions and developed 3 key themes. Now, the full findings can be found in the report, which I do urge you all to read to get the real depth and feel for the insights. But for the purpose of time, we'll briefly present the themes of which all had some great capacity and interesting challenges to meet the AT needs of the population. Next slide, please. So first, workforce and training. We encountered some very passionate and committed personnel who were so happy and enthused to be working in AT, and they loved their job and who they were working with. They found ways to collaborate across other institutions and organisations and supply chains to get what they needed to get done. However, we heard over and over again that there were shortages in staff and it was difficult to recruit to the roles that were needed, as the way to provide AT was changing over time. And not only is there a lack of formalised and recognised accreditation and training for providing AT, so they tended to need to recruit on personality and commitment and passion, which was hard to advertise for. Next slide, please. So moving on to device innovation and maintenance, there are a number of promising practices when it came to device innovation and maintenance in using systems that weren't necessarily designed as AT, but can be used as such as indicated in this quote. And the challenges, of course, numerous, including cost of product, limited choice due to regulations of what could be covered, and users often found themselves using innovative methods to maintain and recycle their loved AT as a way to continue to use them and function. And moving on to the next one, please. AT awareness and uptake. So we found that the awareness of AT was very high in specific contexts, and users and providers knew of the incredible products and of those that were less mainstream. There was also great evidence of strong peer networks where users would share what worked for them, which then increased trust in those products as it was recommended by other users. Challenges included keeping track of new products or discontinued products and changing funding structures to support uptake of new AT. There was also some incidences of stigma where some users didn't want to share or be obvious that they were using AT. And conversely, how stigma was combated through more mainstream coverage of people using AT on the media or on TV or online, which then led to widespread acceptance. I will now hand over to Anna, who will present the final 3 key themes.
Our next key theme is provision infrastructure. And I think one of the most overarching threads of the report that you'll see is the difficulty with high fragmentation in England's AT provision infrastructure. And this makes it really difficult for users to get the products they need. For instance, those users often talked about the system as a barrier in and of itself rather than a provider, citing bureaucratic complexity, differences in processes and criteria across health, social care, and education, and even disagreements between providers about responsibilities. You see a quote here about a user who tried to get a shower chair for 2 years. And she says it was just constant arguments over which area was responsible. It's stressful, it's exhausting. But the system also contains some best practices that, if replicated across, could improve these issues. First, specialist service centers concentrate passionate and expert personnel in hubs where they often work on specific types of AT, like communication or environmental controls. Second, the UK has a really active third sector ecosystem that helps to fill in some government gaps that we're seeing. And finally, there are documented practices, like Delisha mentioned, in personnel of joined up working and flexibility, which could improve system efficiency and user experience if we see them spread throughout. Next slide, please. Next, on to impact data, evidence, and accountability. Across the country, we see inconsistency in data collection and how data is being used to inform service design. In terms of the positive, we do find that some data is being collected and that data shows a really high positive AT impact. And we have case studies in the report that you can look to for more detail on that. And there are some new attempts to collect more data recently and a willingness among providers and personnel to do so. But challenges include a lot of missing data across important dimensions and continuing barriers to capturing it, in part due to fragmented service design, like mentioned earlier, and a lack of reporting mechanisms. Next slide, please. And finally, in terms of budgets and prioritization, some of England's biggest strengths are the funding of the specialized services for AAC and EC, or augmentative and alternative communication and environmental controls. These were designed to act as hubs in each region of England, which serve those with very complex needs. And these hubs were intended to be supported by local services, acting as the spokes of the wheels, the hubs, in providing to those that don't meet regional specialist center criteria. And we see practices of budget flexibility that allow for better prioritization and service provision. So those are a model that we would recommend replicating. However, current challenges include the lack of budget prioritization from local services, meaning that a lot of times the spokes of these hubs aren't in place. And this creates gaps in service provision and competing priorities at local commissioning levels. And participants across the range of those we interviewed reiterated the need for more funded support bodies and the fact that, unfortunately, funding seems to have declined over the last 10 to 12 years. And now I'll turn it over, and we really encourage you to look in the report for some fantastic quotes we had from the users and experts that we interviewed that really elucidate these issues.
Thanks, Anna. So hello there, it's Kate, and I'm going to present to you a case study. Now, we have a series of these case studies within the report, and they really are there to almost bring together some of the findings and voices that we found from our interviews and from our focus group discussions. And these case studies present not an individual experience, but really an amalgamation of what we found. So here we have Dinesh. Dinesh is somebody who has acquired a new spinal cord injury and has been spending time in a rehabilitation centre with occupational therapists, physiotherapists, psychologists, and also the addition of the third sector charitable organisation who's supporting Dinesh to go through rehabilitation and come to terms and find new ways of adapting and living his new life. Whilst in the hospital, Dinesh has had the opportunity to use an electric wheelchair, developing new skills which the clinicians there have been able to adapt and have postural support that feels good for him. Dinesh has really found that this opportunity to sit up and move around and learn these skills has greatly helped him adjust to a new way of life, benefited his autonomy, his opportunity to be independent, and his physical and mental well-being. After several weeks and months there, it's time to start looking for discharge plans. Next slide, please, Louise. What we found is that when the occupational therapist comes to start making referrals to the various services that Dinesh might need to support his journey home, there are in fact barriers. So this particular OT refers to a wheelchair service. They send off the referral, put all the information they have, the various measurements that have been made, and what Dinesh would quite like from his wheelchair. After sending it, they don't receive any acknowledgement that has been received. And it's a series of weeks, months, chasing up to try and find out when Dinesh might get an assessment for a wheelchair. Meanwhile, Dinesh is on the ward hearing rumours that it could be 2 weeks to 2 years. There's a huge difference in what people might have from a waiting time dependent on where they live. So the OT and the hospital start to try and move forward with other plans, and they make a referral to a local occupational therapist who might be able to come in and make some home adaptations for when Dinesh is able to move back to his home with his hopefully new wheelchair. But unfortunately, the OT services who will go in and look at the home adaptations won't go and do that until they know and have a guaranteed timeline of when the wheelchair might be for Dinesh. So you're left in this cycle of no guaranteed time of a wheelchair, no definite that Dinesh will get the wheelchair that he hopes for, and then no idea if he can even move back to the home that he came from. And next slide, please. As you can imagine, this leaves a huge sense of unknowing. Dinesh, who's worked incredibly hard at his rehabilitation within the hospital, has had access to this amazing rehabilitation service where he's worked so hard, is then left in a bit of a conundrum of thinking, will I be returning home in a bed? Because there's pressures on the hospital that might mean that they need to move Dinesh onto a different place so that there can be a bed available for a new person and a new injury coming through. So it's incredibly hard. And Dinesh is left feeling, why work so hard to achieve all of these things if then no one can help me and support me as I try and regain this independence in his life at the other end? And that's really just an example of one of the case studies we found. And it is based on real life example that we were capturing as we were speaking to professionals working in the field who are really feeling those frustrations, as well as the AT users who are at the end of it. Next slide, please. So in this slide,
hey, I'm going to pause you just there.
Yeah.
That's okay. I'm going to just give a second for our BSL interpreters to swap.
Perfect. Thanks, Vicky.
I have to say it's wonderful to have Kate's experience having worked as a clinician in the NHS as well as a researcher and a comms manager on this project.
Many hats. Are we changing? Yeah, I can see that the interpreters
Let's
are
stop speaking and then they
changing.
can.
Yeah.
I'm done.
Just need the new pin, please, team. And I think our video also has subs, so I think we can begin again.
Wonderful. I'm just gonna add a spotlight. There we go. Okay, so I'm going to introduce you in this slide to Katie. Katie unfortunately couldn't be here with us today, but she very kindly recorded a video. She's incredibly busy. She's currently studying for a master's after being a recipient of the Snowden Trust Scholarship. She's worked across policy and advocacy and research roles. And Katie has lots of experience of using a range of different assistive technology in her life. And she's had to navigate things like geographical borders, NHS trusts, and educational settings. She also wanted to share that she's very excitedly recently bought a new house, but now has a bit of a long and complicated wait to have an electric door fitted, which she explains in this video. It's being an incredibly important part for her being able to access her home. So we asked Katie what assistive technology means to her and to also tell us about some of the challenges that she has faced while trying to access it. So I'll hand over the team to please play this video for us.
Let's take Zoe first, if it's okay, and we'll come back to the video because I think there's a, no, we'll go video.
I think that sounds like a good plan, Vicky. Should we go for, oh, we don't have sound at the moment on the video, so I think we'll pause and if we stop sharing screen, and we'll hand over to Zoe, and then we'll sort out the video in the background. So I'll welcome Zoe to please come on. And Zoe is a assistive technology provider who's very kindly come on today to be able to share her experience. So Zoe works as a lead healthcare scientist and environmental control lead working in the Barnsley Assistive Technology team. We asked Zoe what some of the challenges that she faces in providing assistive technology to patients and clients, and what kind of experiences then those clients might have when they're able to access that AT, and what that might mean on a system level overall. So if we can stop sharing the screen for a moment, and we'll ask Zoe to come online to share those experiences.
Hi, everyone. Thank you. And thank you for inviting me to speak today, and the great work that you've obviously been doing in the report. So yeah, just sharing a few thoughts. In terms of the challenges, so I'm from a specialised service, so people have already referenced those in the presentations just. And in terms of electronic assistive technology or environmental controls and specialised alternative and augmentative communication, the change to specialised services, so this idea of high cost, low incidence equipment being provided in regional hubs, was a massive step forward compared with what had been before. There'd been a lot of geographical variation. There'd been kind of short-term funding that then hadn't led to kind of ongoing funding. And so it was a big step forward, and there was quite a lot of levelling out of some of those geographical discrepancies. As was mentioned, the model that was envisaged was this model of a smooth pathway between local services and the regional services, and that you could kind of go between those, and that depending where your need was, that's how you'd fit into that, and that you should be able to get access to those things at all of those points along the way. And that we do have criteria of specialised services and how people kind of meet those and where people come into those. And although being a big step forward in the specialised services, what I think we have got is, although there's some really good examples of local service and regional services linking together, there are also a lot of examples where that doesn't quite work. And that's not due to lack of enthusiasm. It's often due to a myriad of other things in terms of what the system is there, what the funding's available, and all of that kind of side. And what this does tend to lead to is gaps in provision for particular people, and also can lead to some, I suppose, kind of tensions for people, because they feel that if they haven't met the criteria for a specialised service provision, that then they are not able to access anything. And although that shouldn't be the case, that can be how it feels, and very definitely can be how it feels. And I think all of this work that's going on, and we're doing some work locally as well around looking at those pathways and how we kind of make that more equitable in terms of that kind of process, is really important. I mean, I'm a very strong believer personally that not everybody wants or needs assistive technology, but it certainly needs to have the access to be able to explore that and what people can use that for. So I mean, that's a bit on the challenges, and I don't want to there are, but we're always moving forward with those. In terms of the benefits, I think there's multiple benefits that have been highlighted today. For myself and for lots of the people here, probably the main thing is around the impact on a person's agency and belonging. A lot of the people I see, they won't be entirely able to do everything independently in their life, but that having the agency and independence over the things that they can with the assistive technology is essential in terms of their quality of life and that independence and control. But not just for the person themselves, I think for everybody around that person. I think for immediate carers, for people who are supporting, then if that technology is in place, it enables those people to also have that quality of life, also have some level of independence, and also kind of have that balance between relationships and things, and do the things that they need to get on with as well. I often think of an example, and it will tell you how long ago it was, because it's an environmental controls example, and the person wanted to control 5 television channels, so it's back in the day when that was all we wanted to do, and an alarm, and I got called because it had stopped working. So the husband and wife, it was the husband using the technology, and they were really distressed and frustrated because it had stopped working. And it's a very simple system, but when I got there, they were like, you know, his wife was saying, I'm having to rush in and out all the time to see what channel he needs changing. I'm having to keep responding to that. And it's always stuck with me as that we can often take things for granted, but that small change in that independence and control is massively important. Obviously, the impact on many other things such as education and employment is really essential as well. And I think there's just so many things that can be. I think more to the element of the question was around cost savings, and I think sometimes AT can be thought of in terms of replacement or reduction potentially of other services, but I would definitely envisage it as how we can make best use of what resources we've got available, and technology being part of that. So if technology can play a part, then that's really important, but then how do we best use those resources that are available? And I look forward to seeing how this all feeds into things like the Disability Action Plan. Thank you.
Thank you so much, Zoe, especially for taking time out of your important work to share that with us today. And back to our video, I think.
The impact of access to assistive technology on me has kind of put me on a level playing field with others, and I guess the biggest thing is it given me independence that I wouldn't otherwise have had, and I would have been quite reliant on others. So, like, for example, I have an electric door, which means I can come and go when I want, and I don't have to rely on someone helping me go out, which I would hate, and it would really limit what I could do. But I faced a lot of challenges to obtaining accessible technology, especially around the funding and the bureaucracy and time scales that are involved in that. And just like not knowing who to contact or what the process is, and like sometimes the actual professionals don't seem very clear on that either, so it's quite confusing and it causing a lot of delays and knock-on impacts on me and my quality of life. And the other issue I've experienced is you usually get like a 12-month guarantee, but after that it left to me to fund any repairs or maintenance, which can be really difficult and quite a low income.
Thank you very much for that, and it was wonderful to hear that contribution too from Katie. I think we're to the conclusion, which is back to me, so thanks, huge thanks to the team. I guess it was quite stark for me to see these findings because I've spent a lot of time looking at findings in low and middle income settings. We surveyed mainly disabled people and used some magic maths to assess that to the general population. We found that 87% of people surveyed, that's disabled people, needed at least one assistive product, as mentioned, and that was 65% though for the general population. So this is not an issue that only affects disabled people. 31% of those 87 did not currently have their needs met through access to assistive technology in the UK. Unmet need was much higher in London and for young people, quite considerably so for young people. And actually, despite being a social justice researcher myself, differences in gender, race and class were slightly less pronounced than you might have expected them to be. That's not to say there were no issues. Mobility assisted products had the highest rate of unmet need, as Jamie mentioned. Often this is because they're the more complex and more expensive product. and that often exceeded need rate. In terms of capacity, products were generally of good quality when they were provided, and that's different to what you might find in other countries around the world in perhaps lower income settings. But for me, the starkest revelation, and it answers the question also in the chat, is that we were unable to get procurement data across government from different government departments. Perhaps this isn't surprising, since we had a very short space of time and there was definitely goodwill in government to provide that data to us. But we weren't able to find out who is buying what, from where, how many units at what cost. And that's the data that we need to make sure that we're buying the highest quality from the cheapest price. And that's what you see all over the world. But I maybe naively expected it to be different here in England. And if there's one thing I would suggest, is that government takes action to address that, because without knowing what we're buying from where, in how many units and for how much, we can't really take the market shaping actions that might enable us to reduce the price of some of those procurement tenders. As we've mentioned, trust is disincentivized between providers, because providers need to do new assessments every time, and there's almost like a competition operating in some sectors there, and delivery is proliferated across the system. So without a clear picture of who can provide what to whom, it can be quite tricky for AT users or ATech users to get access to what they need. Some accountability issues were also found. Most people had out-of-pocket costs, so 45% of people list cannot afford, as one of the reasons why they don't have AT or ATech. Again, perhaps that's surprising. It's usual in most low-income settings, but perhaps it's surprising in the UK. And this is obviously higher for people on lower incomes. Personnel are an amazing resource. So many wonderful positive stories. But given there's no real AT sector, AT training, AT network, AT support function, oftentimes you have OTs or PTs working in isolation without being able to be supported or have their capacity built. And as Anna mentioned, the AT hubs that have been established tend to be really specific and often lack spokes. The impact, though, is really positive. So the impact on individuals who are receiving assistive technology, 83% said it was really critical and very important at all times, which is really strong evidence that we should seek to address this problem. And in many cases, unmet need individuals simply unable to participate. We made recommendations. I'm going to go through them super quickly by reading only the top lines of the following slides. And please refer to the report if you wish to take any more detail. Next. I guess the first thing to say is that we were surprised. Maybe we were biased, but we were surprised by what came out and the gaps and what might help to address some of those gaps. And actually, we'd done a piece of work reflecting on the Paralympic Games and what the steps were that were necessary to drive forward the mission of delivering the greatest Paralympics of all time, as was mentioned by IPC. And we found these 12 steps to be the most important. Again, I won't go through them in detail, but the idea of setting a mission and making someone senior responsible for carrying that out right across government, getting the right data, getting it to people, getting the product to the person that needs it, reminded us also of the COVID vaccine rollouts. And so one of our recommendations was then to have this senior person in government, which was alluded to by Deb at the beginning. Next. There were some things that we thought were possible to do quickly, setting this mission, appointing what we called a SAR, but actually is probably better as a champion, getting better data, establishing the hub based on the gaps that we see. So as Deb said at the beginning, it was right not to go ahead until we understood what was needed. Now we know what's needed, so maybe it's time to proceed. And also to validate the assistive products list, which we included in the report based on the data collected by BATA and inputted by many other people over the past 2 years. Next. Medium-term recommendations involve incentivizing coordination somehow between the different delivery partners, considering an AT user's passport, as is used in other countries, including, I think if I'm right from memory, Ireland. Getting better information between users and policymakers, so creating opportunities for AT users, disabled people's organisations and others to input into this process. taking action to build capacity of that disparate and non-nominated workforce, so people feel like they're part of an AT sector and feel supported in being so. And then also we were looking at the commitment that the Prime Minister has made on NHS reform and wondering how we could use that commitment and the current white papers to think more about prioritising assistive technology within it. Next. Finally, we came to the longer term recommendations, and that's about how do we build the evidence through investing in physical spokes. And we kind of think the assistive technology global, regional, national centre could be digital in flavour, but with physical spokes. So we were thinking maybe it would be possible to rerun this assessment every 4 years and track progress and change. We also think there's a real opportunity here. The UK, as many people know, is at the forefront of export of many assistive technology products around the world, as well as being the purchaser of many. So matching supply and demand and maximising the possibilities in the market is something that would make an awful lot of sense to do. We didn't want to forget repair. I don't know if Mark will mention this, but we have lots of great ideas about how we could engage together with community organisations and universities, using local centres or shops to focus more on repairing and learning from each other in makerspaces and other places to enable AT users to repair and bespoke their own products. And also celebrating success was a key factor in the 2 examples I gave you earlier, both London 2012 and the COVID vaccine rollout, and so it feels important here too. I think that brings me to partner reflections. So I'm really delighted to be able to hand over to our partner and neighbour, Mark Hodgkinson.
Hello, everyone. Thanks, Vicky. Yes, so firstly, I really wanted to welcome the opportunity to be involved with this report, and in particular look forward to working with everyone to make accessible technology more accessible, cheaper and usable. I think that we talked a lot about the challenges, and it's right to focus on the challenges, but I think the thing that particularly excites me about being involved in this is if we can get it right, we can really unlock the true potential that disabled people have for this country. It's not just about helping disabled people with their lives, which is clearly essential, but we're missing out on the talent and the potential of many disabled people in the country at the moment by not giving them the ability to achieve their true potential. And that, for me, is where we need to focus. I will start with work, and I think it might have been Deborah that said earlier that a lot of focus is on work and education. So I won't just dwell on work, but I think we know that, we've been told that 1 million disabled people want to work, are able to work, and are currently not in work. And a big part of that will almost certainly be that they're not getting access to the right support. So rather than, as was announced earlier this week, as trying to get more people into work by potentially threatening their benefits, I think a much better way to do that is to really seek to boost activity and the economy by providing the right assistive tech for disabled people to make the contribution that they can make. And it also helps people in work too. We did some recent research at Scope that on retention that showed that 50% of disabled people would benefit from an adjustment, much of which is likely to come from assistive tech. So it's really important for retaining people in work as well as opening up those opportunities. As Vicky said, I think there's real opportunity for us to be leaders in this space. The National Disability Strategy envisaged an assistive technology task force, and there was then a judicial review which put many of the National Disability Strategy actions on hold, but that's now released, and therefore it's something that we really think there's every opportunity and should be progressed. Not only can this help us tackle the more immediate requirements, but it can start to position us, not just in England, in the UK, as an innovator, Vicky talked about that a moment ago about the potential for export. We're already, evidencing that we can innovate in this space. And I think if we really put our mind to it, then it's not just about the tech, but it's how it best meets the needs of those who use the tech and how it's supported as well. And again, Vicky mentioned about the fact that it's all very well having the tech, but if it breaks down, can't be repaired, then obviously it's not much use. And I really think there's an opportunity for communities to step up here. And one of the things that I'm particularly interested in is the concept of community hubs around the country where people can get access to advice and also obviously support in terms of either procuring the technology they need. We heard that procurement is potentially challenging. We don't have the data at the moment, but also repairing technology as well. So there's not a fragmented approach, which was mentioned before. There isn't some sort of postcode lottery around what you get and what you don't get. So for me, those are some of the thoughts of potential opportunities that I see from this work. Thank you, Vicky.
Thank you so much, Mark, for that contribution, and also the contribution of your team. I should have also mentioned up front that the data from Mark and his team's helpline call-in was also really helpful to us in designing the flavour of some of the responses that we had on real-life experiences of access to AT. So thank you so much. And we can perhaps get back to the presentation, or maybe it's not necessary to hand across to our next speaker, who I believe to be Cameron. Is Cameron there?
I believe we've lost Cameron.
Just lost him, so I think we can move.
Yeah, we've just lost him.
Yeah, no problem. Yeah. If it's possible, we can move to Nachi's video. Professor Nachi Chokka-Lingham is a professor at Staffordshire University, and they helped a lot with the background of the research for us. Let's press play.
Thanks very much for the opportunity to reflect on our contributions to this overall piece of work on assistive technology. At the Center for Biomechanics and Rehabilitation Technologies at Staffordshire University, we've been working on mobility assistive technology in the form of orthoses and footwear for over 20 years now. We've also been collaborating with various international organizations in this space. A couple of years ago, with support from the World Health Organization through their Global Cooperation on Assistive Technology Initiative, we conducted a piece of work to measure access to AT in the UK using Rapid Assistive Technology Assessment questionnaire. Whilst this questionnaire received a limited response, this is mainly due to the pandemic, the collected data provided valuable insight into the use of assistive products in the United Kingdom. Results highlighted high levels of satisfaction with the assistive products themselves. The services, the repair and maintenance, and the general follow-up were all satisfactory. However, we highlighted that a considerable amount of assistive products were paid out of pocket, and this meant that they are not accessible to everyone. Also, almost 1 in 5 respondents to our survey had an unmet need for assistive products, and most of them said cannot afford, and this was one of the frequently identified barriers to accessing assistive products. Also, during the interviews, it became very clear that there was a lack of understanding on the term AT, and we realized that we were raising awareness of the breadth of products and services that fall under the umbrella term of assistive technology according to the WHO definition. However, our survey clearly highlighted that a large-scale work at a national level would be of significant benefit to us as a country in raising population awareness. The current work that's being reported today fills a gap that we identified in our earlier report, and we are happy to be a part of this. The results and the information from this report will support policy making, and we hope that it will strengthen our AT ecosystem by improving service delivery and a better relationship between all stakeholders. Although we do have quality products in the UK, the current processes need to be improved. From a research and development and also training point of view, we need to provide a step change through structured research into the inefficiencies in our systems. This will also have a huge impact on the AT access gap, which is reported today at 31%. In addition to looking at health and social care systems, we also need to think about innovations and cost-effective AT solutions. We do have a strong academic research community in this space in the UK, but we need support from all quarters to make a difference and fill the gaps highlighted in this report. We look forward to working with you all. Thank you.
And I have to say the prize definitely goes to Natchi for the most professional setup for delivering a video. Thank you to everyone in Staffordshire, including AFA, who also did a great job of contributing towards the research. I think we can take the presentation down now, if that's okay, since there's not much on the slides. I'm going to do a kind of final call for Cameron. Your plane is leaving. Are you able to board, sir? I'm going to assume that's a no, but if he pops up at any time, he can let me know. It looks like from one professor to another, I'm delighted to welcome for her reflections, Professor Catherine Holloway.
Thank you very much, and thank you for this opportunity. I'm always amazed, I'm often amazed that assistive technology is so hard to get to people. And I think we have to really ask ourselves why it's so challenging. When we did a recent review on innovation in the sector for the Global Report on Assistive Technology, it was really clear that whilst there was a huge number of additional patents in this area and a huge number of new product innovations, there were very few innovations in the provision systems or in the procurement systems. And so what ends up happening is that people are creating more and more inventions, which are great, and they're often user-led, and they often do fill a gap, but there's almost impossible to get those to the people who could actually use it at scale. So what we've seen in this report is that England is no different, that services are fragmented, and there's great reasons for that. That, they've come traditionally from rehabilitation or very specific clinical backgrounds or very specific education backgrounds or very specific social backgrounds. But that's fine, that was the history. We're now moving into a new time and a new century. We have an advanced digital world where we can connect records, where we can connect passports, where we can get people what they need when they need it. We, England, and I would say the whole of the UK, and I'd include Northern Ireland, can be part of a revolution in this innovation space. We have the great designs, with great innovations coming out every day, but if they're not paired with this systems thinking that's led by users, we're not going to get anywhere. And we're going to be sitting here in 5 years' time or 4 years' time, as Vicky suggested, we should recheck ourselves looking at the same thing. One thing that Mark highlighted from Scope was the need for community-led work. I have worked in this space for decades. I grew up in a nursing home. I grew up around assistive technology. I've worked in this space all my life, and I use a lot of different assistive technologies. And I can tell you that I don't ask clinicians for help, mostly. I ask other people who have conditions like mine, which software works for you? How do you make it work for you? What happened? And so that community level peer support is so undervalued and yet so rich and actually very cheap. We want to help each other, and we are very happy to do so. And if we could amplify the mechanisms for that community support, we would be moving towards a more inclusive world much more quickly, and with a lot less resistance and a lot less friction and a lot less fighting over the costs versus the benefits. And I think the biggest thing that I would love to see come out of this report is renewed commitment to a shift in mindset. Let's stop talking about how much it's going to cost, or let's stop talking about whether or not people are going to be employable or educated or anything like that. The vast majority of people, disabled people, AT users, will go off and do wonderful things if given the opportunity. And they might be fantastically creative, or they might be accountants. Nothing against accountants, but it could be a whole wide range of things that people are going to be doing. And I think if you take the flip side of that, imagine each and every day you try to do something, and it's a simple thing, like you try and get on a train, you try and go to a toilet, you try to open an email, and every single time you can't do it. And you tell me that at the end of a day, or a week, or a month, or a year, you would still be rocking up to work feeling really happy and excited and wanting to be collaborative, or would you have been worn down? And I think we have to just bear those two things in mind, that if we shift from that sort of daily frustration model to actually they do form quite critical problems, but if we shift that mentality completely to just giving people what they need and developing what we've talked about, fantastic partnerships, which we have great evidence of doing at a global stage. We have partnerships, 73 of them, I think, at the moment, working collectively in something like 43 countries, developing centres of assistive technology which pair how we do community repair, how we do national level service, how we do community-led resources, and how we bring innovative products to market that actually scale rather than just flounder in the world. So if we're able to do those partnerships and grow the partnerships, if we're able to make sure that is led by community as well as the technical expertise that will be needed to infuse that community, and we really look at innovation being not just products but services and provision, I think we have a great chance of shifting those numbers and actually all being a lot happier in 4 years' time. Thank you, Vicky. I'll hand back to you.
Thank you so much for that lovely contribution. Final boarding call for Cameron Malik. Then I think we are back to Deb for any reflections that she has to share with us following that.
Apologies, sorry, I'm just battling my as well. I think it's just incredible to have the what I'm going to call the facts and figures behind what we think or thought we already knew, with some additional illuminations in particular areas. I'm also in a very sort of like civil servanty way wish to be completely non-committal on the recommendations that the report has made, but also recognise a couple of those that chime really strongly with what we're doing at the moment, particularly the ATEC champion. And we've had recently some round tables on the ATEC measures in the Disability Action Plan, where we've received a lot of really helpful and insightful feedback from the wider sector about the potential of an ATEC champion, whether that is an individual in government or whether it's somebody externally, but also how that individual is supported, because we have we've got form in kind of like, you know, appointing a czar or appointing a champion, leaving them to get on with it. But we need to ensure that we've got the infrastructure around that individual to make meaningful recommendations to ensure that we have meaningful change as well. I think as well there's something for us in terms of the pickup of things that are in the National Disability Strategy, and that strategy was published in 2021. We've paused reluctantly on progressing a lot of those because of the judicial review. I'm so sorry, I've got work going on, you can probably hear it. So we paused that, and of course now that the time frame is somewhat compacted for us in that, because we published in 2021 with the idea that we would have 4 years to achieve a thing, and now we're in 2023, we no longer have 4 years of this parliament in order to take that work forward. So I think we're more in the space now of the longer term plans of the National Disability Strategy, and the shorter term impacts of the Disability Action Plan as well. My final kind of like comment reflection, I did say at the beginning I'd pop a link in the Q&A to the Disability Action Plan. I would really strongly and hopefully encourage you to apply on behalf of yourselves as individuals, but also, you know, if you're members of organisations, please have those discussions. Help us build on this research to elicit real change for people, and help us as policy professionals turning those bright ideas into sort of like fundamentally deliverable things that that enhance people's understanding of ATEC, but also, you know, bring about change for disabled people in the England and the UK as well.
Thank you so very much, Deb. That's wonderful. And as promised, we have time to answer your questions. So I think Kate's going to take a few examples from, or some questions that she's pulled out from the ones that are in the Q&A. There's still time to ask your question if you would like to. And let's start. So Kate, would you like to?
Yes, hello.
Or I can simply
Thank you. I'm just making sure that I've switched over the interpreters, okay? Brilliant. So we've had some great questions and comments that have come in. So thank you, everybody, for sharing your thoughts so far. Marie, who works in the South African system, is interested to know which government department holds the budget for education-related assistive devices and whether procurement of these devices are easy to be arranged to support learners with disabilities in mainstream schools. Which is a very interesting question. Thank you, Marie. And there's been other comments as well around that kind of, if we can see comparison between countries to England. So I'll open the floor if anyone does.
I'll start, and then if anyone wants to jump in, that's great. And thanks for the question about comparison too. It is very common in countries increasingly common for there to be a disability line ministry or a ministry with disability responsibility. Sometimes it's in gender, sometimes it's in a wider social development ministry. Usually that ministry doesn't have a lot of money. So usually the role of that ministry is to draw on the role of other ministries to deliver what's needed to support the constituent group for which it's responsible. Often it has a policy role. That's not different in the UK. So that often means that relying on the ministry responsible for education, the ministry responsible for however it's called, social services, social intervention, social welfare, benefits and the such like, and the ministry responsible for business, among others, it's often there that provision for assistive technology actually sits. And the UK is no different from any of the countries I've worked in, which are many, in that respect. Also, I don't think I've ever seen an example where the central ministry or anyone else holds perfect data on what's being bought from who, by who, for who. Now, the problem with that is severalfold. It means that ministries are purchasing the same product, potentially from different sources, and therefore probably not at the best price. To give you an example of the type of cost reduction that we've seen in the global market, we supported UNICEF to bring forward a hearing aid, along with others, into their procurement catalogue, which basically means they agree the price and the quality with the supplier in advance. This resulted in a reduction in cost for the purchase of that hearing aid. In this case, it was by the government of Rwanda, from $2,000 per unit to about $140 per unit. It's a massive reduction in cost. Now, the situation in Rwanda may not be entirely comparable with the UK, but I rather naively expected that the NHS and the health ministry would have really, really comprehensive data, and it might, but in the time frame that we were given and with the extension of access that we had, we were unable to find that data from, I think I'm right in saying, any government department at all. And so I think it's really important that we notice that the types of things that are called market shaping in other fields like vaccines or other products that are used in medical settings internationally. So action to buy high quality products at a lower price for a guaranteed volume of people, they're not possible unless you have good procurement information. So I'd 100% underline what Professor Holloway said about service intervention and procurement intervention. Also, the UK is in possibly the perfect position to do this, because it has will, it has political knowledge, it has a centralised health provision system, which Every time I go to another country, I'm asked, how do we have such a beautiful and wonderful NHS? So there is a chance to do this, and it might not be as hard as it sounds, but it's probably going to involve someone really senior telling some people that they need to get this data and bring it all together in one place and make some decisions. I don't think the decisions are that hard, and I think they could even be efficient cost-wise, but they can't happen until we know what it is we're trying to address. I don't know if that answers the question, and I'll be quiet and let anyone else jump in.
I think you did a good job, Vicky. We can move on to the next one, Kate.
Well,
yeah, so maybe what's the next question? Zoe, I might just actually, I can see you're typing an answer, so I wondered if you wanted to come in and answer this one live. So the question is about the need for innovation in the systems for driving adoption of assistive and accessible technology, not just in the tech itself. How can we innovate in the way we raise awareness of ATech across society? Great question. So Zoe, would you like to answer that live?
Yeah, I'm not sure I've got a great answer, but I was kind of chatting to agree with it. I think it's really important, and yeah, really totally agree with your points around it, that, you know, we've got lots of innovation in the actual tech, but it's around the innovation in how we get the tech to people and raise awareness. I think there was mention of the roundtable earlier in the week and the kind of consultation around the Disability Action Plan, and something that with some colleagues we've been talking about is a kind of framework around training. Again, that doesn't, there is a much broader, which I agree with the point made, I think that much broader kind of societal awareness of AT, but also if you do need that, you need to know a bit more about AT. It's not easy to find where to plug into that and at what level, and that there is lots and lots of resource around. I think that's similar to there being lots and lots of technology around. It's not through a lack of that, it's more a lack of how we kind of navigate to those things. So this idea of a kind of framework at which you could dip into to find out, you know, where you're coming, you know, perhaps as a carer who's just started working with someone who's using some kind of assistive technology, or if you just want to raise your general awareness, or perhaps if you're working in a school, that you'd be able to plug in where you're kind of at the moment and then what training's available. But the idea of undertaking some work like that would be to find the gaps in that. But I do think there's something around, and I think over the last couple of years we have had, and it's not just reliant on kind of people who are in the media spotlight, but we have had much more of that. We've got, you know, examples like Rob Burrows using eye gaze in which in, you know, is very high profile. You know, Lost Voice guy, there's a lot of people where we're starting to see that, not just the focus on the technology as the kind of reason it's being portrayed, but actually it's just there as part of something that's being used to enable them to kind of fulfill what they want to achieve. So either the comedy or the fundraising or that side is part of that, but the byproduct is that we're seeing it. I was very excited to see, you know, the first communication aid on the CBBC bedtime story. Made me very excited, but like probably everyone else wasn't thinking about the eye gaze technology apart from me, and people in our field. So I think how, you know, a big coordinated kind of push to kind of raise that awareness is really important. But then where do people go if they need a bit more than that as well, of that kind of idea of how we build the training and the awareness, and at lots of different levels, to kind of access that. And I think that's really important.
Thank you so much. Does anyone else want to comment on that one? Otherwise we might move to the one about gaming.
Well, I might just jump in, Vicky, to build on it maybe, because I think that the question about coming in around innovation and innovative products is, and there's a few other questions that talk about how community-led or user-led innovation can happen and repair can happen, and those things are so absolutely important. However, honestly, I think the repair and the service is really critical at the moment. I think that whilst we can still innovate in products, and I believe the UK can be a powerhouse in this area, I really do. We're seeing, for example, at UCL East, we've got a good collaboration now going with the Institute of Making and GDI Hub, and we're beginning to explore how we would run repair workshops for people to come in with their assistive technology, how we would run an open source repository for people to learn how to have digital skills and make their own technologies. And I think those things are incredibly important. And equally, it's important to have things that you don't have to prepare yourself. So we need this diversity for people. Sometimes people like to do it themselves, and some people they don't. So we need this diversity of services and systems. And I think we're working with a lot of colleagues, for example, the new health centre at UCL as well, to see how you can integrate business models that integrate local repair as well as system level repair across country. And I think those things together with innovation pathways for products will lead to some great things. I'll hand it back to you.
I'll add one more thing to the issue of innovation. I think it's also important to talk about not innovating just with products, but also with policy, because I think what we see from the assessments data is that one of the strengths of the UK is the array of products and the fact that when people do receive them, they're overwhelmingly pleased with them, though certainly some problems remain. The problem is in getting people those products, and it's very difficult to innovate in policy in the current system that we have. But you do see abilities to do it. Ireland right now is piloting an AT passport system, and we in the UK have the opportunity to do other types of policy innovation, of systems innovation, if we were only to take advantage of the expertise that we have here.
Thank you, Anna. 100% plus one. Lovely. Kate, do you have another question ready? Otherwise, I can add one.
We've got the gaming question we can go to.
Let's do it.
Which is a question that's come in from somebody who's picked up on the comment about tech for enjoyment. And what did we find about accessible computer gaming, for example, adaptive controllers? Are these products widely used, known about by disabled people?
Who wants to talk about gaming and inclusion?
Zoe has her hand up, so I can also jump in if you want.
I'd be happy to come in. So in the environmental controls criteria, we do cover computer access, and this was a very new thing when the service specifications came in. So I have been in assistive technology for about 20 years, and when I first worked in environmental controls, computer access wasn't routinely part of it. So I'd go into people's houses and I'd be like, what do you want to control? And they'd be like, I quite like to control my computer. And I'd be like, oh no, we don't. We don't do the computer yet. But luckily, I didn't feel comfortable with that, by the way, but it was what we were working with at the time. Luckily, that changed when we had the specifications. But what we've recognised as an environmental controls community over the last period of time, that obviously that computer access and what we provide access to is growing, and also that our games consoles and things like that are a massively important part of how people want to do gaming. But also, I think we recognised in the pandemic that people could use that very much for their social interaction and communication in those online communities, and that it's not just, you know, it is about gaming, but it is about much more than that, and that there are options available in terms of that access, and that should be considered as something that's part of that bigger picture in terms of providing access. We are undertaking some work to look at how that fits into our kind of specifications, but similarly to other things around the specialised service specifications that we've talked about today, there are kind of criteria around that and that kind of accessibility to that. But it is something that's there. In terms of kind of the technology for that, that has really grown in terms of some of these adaptive controllers that are the same price as a standard kind of gaming console link. There are charities that have got great deal of knowledge around it in terms of people like Special Effects, and so I think what I would say is that there's lots of potential there, and there's opportunity and there's technology, but also then there is a look at how we get that provision wider, but it fits into that whole bigger picture of where the gaps are in terms of whether you meet certain criteria, and then also work to recognise, you know, sometimes you have to break down barriers around things like gaming, because there's some sensitivities in terms of whether who should be providing access to that, and where does that fit. But we would very strongly feel it fits in terms of that independence and independent control and agency. And also I think there can sometimes be a bit of an impression that the people who are gaming are kind of 14-year-old boys, not that there's anything wrong with 14-year-old boys, but actually it's not. It's my nearly 50-year-old husband, and you know, and there's lots of people with kind of degenerative conditions and things like that. So we're not just taught, you know, that's it kind of can fall into a particular category, but I think it's a much wider picture, but also fits into that. How do we look at provision in the whole and the round, and how we're trying to achieve that independence and control? I hope that goes some way to answering where something part of it is in terms of gaming.
It really does, Zoe. And I'll just, before I turn to Kathy, it's a pre-warning of the panel that I'm going to come to you for one final set of words / sentence tops on what you think we should take away from this. Kathy.
I was just going to say there's a question as well from Mark Goblot, hopefully I got your name correctly, just about disabled consumer choice as well. And I think there's always this this tension maybe between what is a human right in order to level access, and then how do you also have consumer choice? They shouldn't necessarily be different, but they can be sometimes. But one of the things I found with things like gaming, like the Microsoft Adaptive Controller for Xbox, it's often not in the right places for people to know it exists. Like, I know it exists, but why isn't it in every NHS clinic where a lot of children who might need it are waiting for a lot of appointments and their parents are sitting there having struggled to get them there? And that's where it could be used, right? People could be getting excited and enjoying themselves while they're just waiting in a waiting room. So I think that we need to think a little bit more about how we make the entire system proactive in helping people understand what's available, what can be available, and linked to that are things like, for example, Google. So I've mentioned Microsoft, I'll mention Google. Google have recently launched their Relate app for dysarthric or slurred speech, and it's just an Android app. Anybody can download it. It works in English only at the moment. But a lot of speech and language therapists don't know it exists, because speech and language therapists are just constantly bombarded with their clinical times. You've got like the MND Association going off and telling them, but really we need a central place where people can come and know these technologies have now been launched. Here's some training, some online training for you, if you'd like it, or just some awareness. And this is a sort of a one-stop shop, so you don't have to keep going to very many different places. And that can be my last contribution to you, Vicky, if you're running out of time.
Thank you. We'll pause for a swap on the BSL. Great, so I think we're probably coming towards the end with just 2 minutes left. So I'm going to come back to everyone in the order that you're on my screen. So sorry, Anna, you're first. What's your final sentence that we should take away from all of this work?
My final sentence is that AT users are often the biggest experts in this field, and we ought to listen to them and draw on their expertise to know what works.
Perfect. Leisha.
There are so many challenges, but there's some great stuff going on in the field, and I think if we keep collaborating and sharing, we can make a big difference.
Kate.
I've learned that it's quite hard to spotlight and talk at the same time. But I've also learned that collaboration is so important across all the sectors, and I definitely think there's a lot that could be done there across data sharing and many other aspects.
Mark, whose research we did post just below on gaming from Scope. Mark, to you.
Yeah, I'd highlight potential, which is how I started with my comments on the panel. I think I'm actually really excited by what we might be able to do with community hubs. I think there's lots of potential there, and one of the things we at Scope are really interested in is focusing on where there are gaps and how you might address those gaps across the country. So yeah, I'm looking forward to exploring that a bit further.
Yeah, +1 on that. Zoe?
Yeah, I'd echo all the things everybody else has said around, the essential and the massive importance on the lived experience. I think we have talked a lot about the challenges, but there is some really amazing stuff going on, and there's really great examples of good practice. And I think we need to really think about how we work together to build on those and bring those together and not reinvent the wheel. I mean, I speak as within the NHS, we do lots of good things, but we also can be quite good at reinventing the wheel. And how do we share that knowledge? And I suppose it talks to that point of that kind of central place to go to, that central place to know what people are doing and what people are exploring, so we can all build on top of that. So yeah, thank you.
And thank you, Zoe, for taking time out of your clinical practice to join us today. I think I missed Jamie.
Right, as the data science person, my comment will just be about the data science, but this whole project was one of the first times we've had a collaboration of having like a really large population-based survey, and then also having these interviews, and then having like working with so many partners and stakeholders. And it's just been wonderful to see how these different types of data really fit together to inform, like, you know, not just the scale, but like which are the gaps, what are the themes, what causes the gaps specifically, and how does that like experience play out. So I hope that this is kind of setting the stage for more projects where we have like a collaboration of evidence to paint a much more comprehensive picture and give us like very, very practical guidance on how to move forward and actually like fill some of those gaps.
Thank you. It was so good. I'll forgive that it wasn't one sentence. Thank you so much, everyone, for your contributions today. I think let's get together and continue to work on the bringing together of resources and capacity to drive change. It feels very possible with just a few tweaks and some prioritization. So for me, let's move forward on that 80 centre and see what we can do to make real change and get that number of 33% down by 4 years' time. I have to thank the partners who've been only a joy to work with, especially those that provided data and inputs. Again, big shout out to Bata and Opinion, who haven't spoken, and Cameron, whose team and input was fantastic. And a huge thanks to my team, who some of whom are young, but all of whom are just the most brilliant people that I've had the opportunity to work with on this project. Next up, Sri Lanka. This approach is hopefully going to be undertaken next in Sri Lanka. So UK is kind of setting the tone again, but thank you to everyone, and thank you again to Disability Unit for commissioning this important work, and we look forward to seeing it taken forward. If any of you are desperate for more disability innovation chat, you can join us at our summit next week, which takes place on Queen Elizabeth Olympic Park on the 13th and 14th. And you can join us online too. I think where registrations are up to over 1,000 now, so get your place secured and listen more to insights from us and others. Thank you all very much. It's been an honour to be your chair today.